I'm Dr. Rachel Hollander of Hollander Holistic Health, and I coach clients all over the world from a variety of neuroplastic health conditions, including chronic pain, long COVID, chronic fatigue, and more. Today, I'm really excited to be talking with audiologist Dr. Marcia Dewey from Froedtert and the Medical College of Wisconsin in Milwaukee about
Hello.
tinnitus and sound sensitivities. But first, please like this video and subscribe to my YouTube channel at Hollander Holistic Health. It's free to subscribe and you'll get more videos like this in your feed. So Dr. Marcia Dewey, please tell us about yourself and tell us more, what is tinnitus?
Excellent. Well, thank you for having me today. I look forward to being able to talk a little bit more about this and get this message out there for people. So first of all, that's a great question, is what is tinnitus? Tinnitus means you hear sounds inside of you. And that's what it means. So if you're experiencing sounds inside of you that are not coming from the outside, that is tinnitus. And I think it's also important to know that tinnitus is actually normal. Every single person experiences it. If you're a human in a human body, you have heard noises inside of you. We all have. And in the medical community, we sadly pathologize it. We make it seem like it's a disease all on its own, which it isn't. It's actually a natural benign process that happens in everybody at times. And I work with people with tinnitus where it's either all the time or it can be intermittent, but it's distressing and it's impacting their lives.
Yeah, and it could be like a ringing in the ear, a buzzing, a hissing. What other unusual or usual ways have you heard people describe it?
Yeah, thank you for clarifying that, because oftentimes you see the word tinnitus and the next will say ringing in the ears. And one of the things I always tell my students is don't ask someone if they have ringing in their ears, because all you're going to find out is if they have ringing. And as you said, it can be hissing, roaring, buzzing, humming. It can be pulsating. Some people hear songs. They actually hear a song playing. They can hear, it might sound like voices. Which is different from an auditory hallucination where someone's actually speaking to you, but it may sound like voices or it sounds like a person talking in the background. It can pulsate. You can actually hear physical movement in your body. So even our eustachian tube behind our eardrum opens and closes. That makes noise. We hear it if our ears hear. And blood flows in and around our ear and in our head. And so we can sometimes hear that. So sometimes we're actually hearing mechanical processes too. So any sound you're hearing and it's not coming from the outside, again, it's tinnitus. Most of that tinnitus is generated by the brain. I mentioned that there's a small amount that can be mechanical, like movements of muscles and blood, but vast majority of that is actually being generated by the brain.
So tell us more about your general background and how you found out about neuroplasticity.
I've been an audiologist for 27 years. In the summer of 2008, I did my first training and more extensive training in tinnitus. It was a 2-day training. One of our ear, nose, and throat physicians said, I'd really like you all to know more about tinnitus. So I did that training. That was the summer of 2008. So that's almost 18 years now. After I did that training, two things. One, I realized there was a lot more to learn. And two, it piqued my interest. So then that interest kind of took me down learning more. And then that interest became a passion. And then that passion became our tinnitus and hyperacusis programs. We've seen many, many people through the years. The gold standard for tinnitus treatment is something called tinnitus retraining therapy. That model really was developed by someone named Pavel Jastroboff, and it really has to do with understanding what tinnitus is, that it's neural pathways in our brain. Sounds familiar, right? That we use sounds to help to distract us, or we avoid silence. So a lot of avoidance. And then also teaching that it has to do with the limbic system. So those brain processes. Also learning about how it involves our nervous system, the automatic nervous system, and a stress response. So those of you who are familiar with neuroplastic symptoms, you've probably seen some overlap already. So it wasn't a big stretch for me when I did ultimately come across neuroplastic symptoms, because the basis of the tinnitus treatment that I was providing was saying, we're going to use some avoidance strategies. You're going to use sounds to distract you. And then in the meantime, I'm going to educate you about why tinnitus isn't, you don't have to fear it so much. But that model really says, we don't get rid of tinnitus. We're going to change your reaction to it. And one of the gold standards for treating tinnitus is cognitive behavioral therapy, or CBT. But it's very much like CBT, the way that it's used in traditional chronic pain models, which is coping. So CBT for pain and tinnitus is traditionally you're going to get on with the business of living your life, despite the fact that you will continue to have pain, you will continue to have tinnitus. And then I came across the neuroplastic world in 2020 because the Curable app popped up somewhere on a social media feed. Pain and tinnitus, obviously in the neuroplastic world, they're very intertwined. They're essentially the same, which we'll talk about how those tools apply for both. But even before I came across that, I already knew, and there was already in the literature that tinnitus and pain were very similar. And so it wasn't a big leap for me because the tools I was already using really kind of complement the neuroplastic model. And I knew that pain and tinnitus overlapped and were very similar. They're brain generated, there's sensations in our body. So when I saw a pain app, I was like, yeah, let's check that out. And that just was a rabbit hole that I just jumped right down. And what I say now is that, that TRT tinnitus retraining model, I'm still using like 85% of that, but that 15% difference has made all the difference.
Amazing that in audiology, you were learning 85% of what you needed to know to retrain tinnitus in kind of a neuroplastic way. But then there was just that extra bit that learning the neuroplastic model really helped.
Our patients were getting better. We were helping people. I didn't have a program and 10 people out the door with no help at all. A lot of the people got better, but I think they get better faster. I think that people who before weren't getting better are getting better now.
Tell us more about the additional 15%.
Yeah. So I would say the biggest difference is, again, if we look at that CBT model of it's all about coping, and you look at the neuroplastic, we're still using CBT, right? And what we're saying is, you're not even broken. You're not even broken.
Downplaying fear.
Yeah, you're not broken. There's nothing to fear here. The sensation is safe. It is benign. And then turning towards it. So we can talk a little bit about how I apply the PRT or pain reprocessing therapy instead of TRT, PRT. That also includes avoidance, as I mentioned with tinnitus retraining, but it also includes exposure. And that's that difference is I would have never thought to say to my patients, we're going to actually look at your tinnitus. We're actually going to pay attention to it. I want you to look at it. I want you to listen to it. I want you to put all your attention on it. I never would have had the guts to say that. I remember having a patient years ago that came in and he was like, I used to be able to just meditate and I could turn my tinnitus off. And I was like, oh, good for you. I don't know how to use that. Now I do, so that's the big difference is things like somatic tracking and turning towards rather than turning away. And even now when I sit with a new patient to see me, usually that's a 2-hour appointment, maybe a little longer if we do testing. And so we do the testing, we explain it. And then I set up the model and people are very receptive to it. Again, because the theory out there around tinnitus, if you Google tinnitus, you're probably going to see that it is in the brain. So it's not a leap for people at all. And also because we hear it in our head, people sort of understand that it's in our head. But it really is easy by the end of that 2 hours. Most people, I would say maybe 70% of people, I'm explaining somatic tracking even in the first visit. And they're like, oh, that makes sense. They don't always do it, but a fair amount will do it. And then I say, when you walked in the door 2 hours ago, if I had said to you, hey, what we're going to do today? We're actually going to listen to your tinnitus. You would probably have run out the door screaming. But if I build it up and I give you the education and you really can understand it and I show you the test results and I explain it from the view of a medical professional who specializes in the ear, then they can really see that and they're open to that. And so that fear, as you said, falls away. And that's the big difference. And that's a huge difference. Yeah.
So how has your practice changed over time? Did you always have 2 hours for a first visit, or is this something that your medical establishment allowed as they got used to how you were doing this? How did that change?
So we always did testing, and that takes, we usually would do like an hour or more. And then we used to actually do extra testing. So we would sometimes do an hour and a half and explain results. And then we'd send them over to the physician, and the physician would say, I can't do anything. There's no cure for tinnitus, right? So after I did that training and I got more comfortable, I said, we can evolve this. We can actually have the testing appointment and let's add a second appointment once we had the knowledge that's longer. So we kind of have two, an hour and an hour. But that was really quickly within the first maybe 2 years of starting to learn about tinnitus. And that's when I was like, I think we have a program here. And I actually went to all the physicians and I said, how about instead of them seeing you, they see me and my colleagues?
I'm
And they
sure
were
the
like, yes,
physicians like
please.
that, honestly.
Yes,
Like,
your visit. Yeah,
please take care
please.
of them. I don't
Thank
know how to
you.
do it. Yeah.
Exactly. And they need someone who can sit with them and say, wow, this is
At the
scary and this
time.
is stressful. And using a stress inventory with my patients from the very beginning. So I always, and that's part of that narrative with even traditional tinnitus, is it's very tied to stress. We see stress and we see tinnitus come on. So the onset is often, not always, but very frequently associated with stress. And so getting really good at just sitting with a person and saying, wow, there's a lot of stress and this is why it's involved, your limbic system, your autonomic nervous system. And they can see that, and just seeing that connection can help people. So it wasn't always 2 hours, but for a very long time it has been. We're very fortunate like that. So
Yeah. And it is so common, as you know, that patients who have tinnitus have all kinds of other neuroplastic symptoms.
mhm,
They could
mhm,
have a dozen or more additional
mhm,
neuroplastic symptoms. So do those
mhm.
ideas come up during the session, at least in name?
So one of the things that's associated most commonly with tinnitus is what we call hyperacusis, or sound sensitivity, being sensitive to sound. So about 40% of those with tinnitus will also have sound sensitivity. So if you do tinnitus, you're just going to have to do sound sensitivity. So I do that as well. And so that's the most common. But also, one of the more common ear neuroplastic symptoms is dizziness, because our inner ear is part of our balance system. And when that inner ear, you can have different structural tissue damage that causes vertigo or spinning sensation. Those things heal. And for some people, they don't heal and they get stuck in symptom. And for some people, they start without any damage at all, which is neuroplastic symptoms. So that tends to come into our clinic. And at this point now, our physicians actually know, like, well, let's send them over too, even if they don't have tinnitus or sound sensitivity. One of my physicians joked, like, well, are we going to call the program tinnitus, hyperacusis, and dizziness now?
So it'll be a whole
It'll
string.
just be, or just neuroplastic symptom, right?
Yes.
But you're right, they can have all kinds of other ones. And you just mentioned long COVID. So we know long COVID, and I see a lot of head injury as well, post concussion syndrome. So these happen to also be very frequently the symptoms you see with that are fatigue, but dizziness, sometimes sound sensitivity. So those are very frequent, and maybe tinnitus, right? So they overlap. So it may be that the person has those symptoms as part of a bigger diagnosis of long COVID or post concussion syndrome, things of that nature, which post concussion syndrome is also neuroplastic. Concussions heal 2 to 4
Chronic
weeks,
headaches.
unless you have another concussion while you're healing. But typically, if it is a concussion, which is mild, it's going to heal. It heals. And if it heals and your symptom doesn't turn off, that's neuroplastic.
Mm-hmm. I think
Mhm.
tinnitus is so interesting amongst all the neuroplastic symptoms because it is so clearly a brain alarm bell. It's or whatever sound it is,
100%.
it's an alarm bell. What do you think about that? How it's
I
trying
love
to
how you
tell us
said
something.
that. Yeah, I literally say that to the people I work with. So I'll say, I'll say it's a danger signal. It's alerting you to something, and it could be stress, right? It could be emotional things. And I'll say, how much clearer can your body be than literally having an alarm go off inside of you? And that's like an aha moment for them. And
I wonder how many, a general percentage of your clients or patients really have it that it's just there all the time. And I know that can happen, but would you say it's more so that it's coming and going and people
yeah,
might see a connection with
yeah,
emotional
I
things?
love this question too. Great questions. So when we have them fill out quite a bit of paperwork before they come into the program. And one of the questions is, how much of the percent of the time are you aware of your tinnitus? And how much of the percent of the time do you notice it, right? Or are you bothered by it? You're aware and you're bothered. And I would say the vast majority of people are writing 100%, 90% on both of those. Now, again, if someone says, I notice it 100% and I'm bothered zero, I'm just like, good luck to you, get a hearing
Do they
test.
ever
Make sure
say
you,
that?
yeah. But honestly, 80%. So the statistics tell us that 80% of people who experience tinnitus are not bothered by it. Now, those who have a tinnitus that's bothersome are thinking, how is that possible? And that's one of the ways that tinnitus and pain are a little different, because if you're experiencing pain, most of the time you're not liking it and you're wanting to get rid of it, right? And we've all experienced mild pain that we sort of push through. But tinnitus, people can experience tinnitus. Vast majority, 80% are actually like, yeah, that's a sound, no big deal. And that can be hard for the 20%. Now, I'm working with the 20%. The 80% aren't even seeing me. They may be seeing my colleague because they have hearing loss and they're like, oh, I hear a noise. And then my colleague says, does that bother you? And they go, no. And they go, we're good to go. So that's interesting. But so the 100%, how much of the time, most people who have distressing tinnitus, they usually say they hear it all the time, vast majority. Now, I don't know that that's true. And why I say that is, again, the question is, how much of the time are you aware of it and how much does it bother you? But I will actually sometimes say, are there times that okay, so you're telling me it's on all the time. Okay, I believe you, right? But let me ask you another question. Are there times you don't notice it? And well, yeah, when I'm watching my favorite TV show, or when I'm playing with my kids or my grandkids, or when I'm at work, I get engorged in my work and it's great. I don't even notice it at work at all, but they're convinced that it's there all the time. And I used to believe that up until I did my PRT training. And in my PRT training, Alan Gordon was talking about working with a client.
The author of The Way Out.
Yes. And the developer of PRT, pain reprocessing therapy. And he said he had a patient that came in and, he assigned them like, go home and do this graded exposure, whatnot, and come back. So when they came back in a week, all right, so you were supposed to go out in the yard and do some gardening. How did it go? I did it. And did you have pain? And the person said, I don't really remember, but I'm sure I did. And he said, pain is a conscious experience. If you are not aware of it, you're not experiencing it. And that was my aha moment. Like, why am I not saying that to my patients? Because I was saying, oh, yeah, it's probably always like I was right on. Yeah, it's always there. It's always there. And it just doesn't turn off. But, you're just not noticing it. But as soon as you think about it, as soon as you look for it, you're going to find it because it was always there. Now I'm saying, well, if you're not, I'm asking them, are there times you're not noticing it? And almost always, almost everyone will say, yes, they can find a time where they're not noticing it. And so then I present this option. Could it be that your brain has actually turned it off? You're not noticing it. And then if you think about it and you go looking for it, your brain may then be initiating it for you. And I believe that that is the truth. Because once I work with someone and they really stop to fear their tinnitus, this is the difference. In the original model says you don't get rid of it. It doesn't go away. It does go away. It does turn off. Now, I'm not saying like that and magic for the rest of your life, you're never going to hear tinnitus, because every single human being hears it. So you're still going to be a human being. I'm not going to take you out of your human body. I have human experiences like pain, like tinnitus, but it means that there are times that it will turn off, or it'll turn down so low you don't notice it. That's about the same thing, right? If you're not noticing it, you're not noticing it, you're not experiencing. So I say, if you are not noticing it, that means you're not experiencing it. And if you're not experiencing it, that means you're not experiencing it. It's not happening, right? And then when they get
these neuroplastic symptoms only matter if we're worried about it, if we care about it. And so much of recovery is not necessarily that your heart palpitations, your benign heart palpitations are going to be completely gone, but that you no longer care. Like, honestly, I still have heart palpitations. And of course, they get worse if I'm stressed or whatever, and it's a sign to me. But most of recovery is you're able to get back to life. You're able to.
It's funny because actually, when people I work with really get there, they'll come in and they won't even be able to find it when they look for it.
Oh, wow.
So I'm like, it's obviously off, because even when you're looking for it, right? Now, again, it doesn't mean never, and they will. And then, like you just said, when they do notice it, it's usually then they can attribute it to emotion or stress. And like, I'm also human in a human body. My neuroplastic symptom is back pain. I hardly ever get it, but right now is very busy at work. We're coming up at the end of fiscal year. Lots of stuff is happening. A lot of projects I have to get done before the end of the month, and my back's tweaky. But I know by the end of the month or before, it'll be gone, right? It's stress related, and I'm being kinder to myself, and I'm saying no to requests. and I'm putting up boundaries. Like, I don't have the capacity to do that right now. Call me in July. Yes, I want to get together with you, but I have a lot of other stuff going on. So the difference is it can turn off. And the other thing, I was just listening to one of my colleagues in this work is Dr. Yoni Arthur, and she specializes in the dizzy realm, but she overlaps in tinnitus. Like, I specialize in tinnitus and overlap with dizziness. She just did an interview with Dr. Howard Schubner for his new book that dropped
Unlearn Your Pain.
May.
The new white, let me just say, the new
Yes,
white covered, because it's so confusing, the new white
yes,
covered book called Unlearn Your Pain with a different string of words after it that is
yep,
not the workbook. The workbook
that's
could
Unlearn Your
have
Pain.
trees on it or it's purple and black, which I use a lot
Yes,
with clients, but they're all
yeah.
great and they all overlap.
They're both
So,
great. Yes, exactly. But she was talking with Howard and she was talking about this different model. And she says, yeah, in tinnitus, the model is coping. So if we tell them that the best they're ever going to do is cope, why would they ever do better? That's the
they're already
nocebo.
afraid, like, I'm just going to cope for the
Right.
rest of my
You're
life.
not going to get rid of it. And again, that's the TRT model. If you type in tinnitus retraining therapy, you're going to see it's going to say you don't get rid of tinnitus. I just was reading a post for a very big app on tinnitus, and it said, one, it says tinnitus doesn't go away. Two, it says, this bothered me. It says tinnitus doesn't go up and down. You're just in a quiet room and you notice it more. I'm
Uh,
sorry. Are you a human? Have you ever heard tinnitus? Has it turned off? Does it get louder?
I have
It totally
another
gets
thought
louder.
about that. So I said when I was a primary care doctor for about 10 years, because I believe I found this in UpToDate, a medical database
Uh-huh.
for doctors. I think I found it in something because I was trying to research and honestly, I'd never heard of tinnitus retraining model at
Mm-hmm.
the time, which that would have been nice to even know then. But what I told people was kind of a mix of trying not to scare them too much, but I think in the
Mm-hmm.
end it did. It was, well, it's just a sign that you've had some hearing loss. What do you think about that? I mean, it freaks
Mm-hmm.
people out. They're, as with any neuroplastic symptom, they're worried that there's something really bad going on or that
Yeah.
something could get worse. So, what do you think about that? This idea that it's a sign that you have had some hearing loss.
Some damage. Yeah. So this is very important for people to understand. And the way I've thought about tinnitus now is sort of there's three categories of why tinnitus would start. And one is there truly is structural tissue damage. We see that a lot. Tinnitus is the ear's equivalent to pain. If you hurt your body, your brain turns on pain. If you hurt your ear, you can get pain depending on where the damage is, but also you can get tinnitus. It's very frequent. If you go to a loud concert and you do not protect your ears, it is over 85 decibels. You stay in that environment long enough, your brain will turn on tinnitus to tell you, please don't do that again. So listen to that danger message. If you have an ear infection, if you have Meniere's disease, otosclerosis, acoustic neuromas, things like this. But here's what's interesting. I actually looked up the literature. How much percent of times when we have neuroma do we have tinnitus? And it was like 76%. That's a structural thing that's real, that's there, that we can measure. It's a tumor. There's a tumor in the middle ear, plesiotomia. What percentage of those people get tinnitus? It's less than 50. So even when we have structural damage, we don't always get tinnitus. If we do, okay, it's a danger signal, but it can still turn off. That's category number one. So very clear structural damage, I'm getting a symptom. Number two is benign conditions. So I slowly have hearing loss. Maybe it's due to some noise exposure over many years. Maybe it's due to aging or genetics. And it's not a disease process like those other ones I just named. But what that is I'm sitting in a quiet environment more because I have hearing loss. And there's actually a study done in the 1950s. It's been replicated several times, same results. They took people with no hearing loss, no ear issues, no tinnitus. They put them in a sound treated room. And 94% of them in 5 minutes or less heard sounds. Those sounds were coming from inside because they didn't play sounds. So we know that if we sit quietly, we will hear sounds inside of us. So people who have more of a benign type of hearing loss, it is associated. It is common that we start to notice internal sounds, but it doesn't mean that the tinnitus is a disease. It's a pathology, right? And the third category is nothing's wrong with your ears at all. As we know with other neuroplastic symptoms, it can come out of nowhere. You don't have to have had COVID. You don't have to have had a head injury. You don't have to have any damage at all. You can just, your knee can start hurting. Your back can just start hurting,
Mhm.
So I think you're right. What we want to do is temper education with fear, that fear message of you do have some hearing loss, but it doesn't mean that your tinnitus can't turn off. And the best evidence, we're all about collecting evidence with neuroplastic symptoms. Hearing loss is stable. It rarely changes, it might drop a little or it gradually changes over time, but it doesn't, even if you have an acoustic neuroma, even if you have, that's going to change gradually. It's not going to drop and get better. That's what tinnitus does. So hearing loss looks like this over years, even with structural issues. Tinnitus looks like this from day to day. It looks like this in the morning and this at night. What's that about? That is not
so similar
structural.
to pain. Yeah,
Right.
like you're saying.
So even if there's a structural thing, if your tinnitus is doing this, it's neuroplastic. It is neuroplastic because you're almost never. Meniere's disease, it can drop down and come back. But again, that's over days, not throughout a day. Right.
Yeah.
And neuromas slowly grow. They don't go like this.
In addition to pain and I add symptom reprocessing therapy, PRT, to help tinnitus, what are your thoughts about emotional awareness and expression therapy? Do your clients, I say clients because I health coach, but your patients, do they mention maybe over time as they're learning more about this? Oh yeah, I noticed that when I was kind of thinking about something frustrating, it came on, or I was afraid of something.
Oh, for sure.
Yeah.
Just the patient I was working with today, I followed up. This was our third time meeting. And the first one was getting her all the information. And then, so now we've followed up for our third time total. And we were talking just about that and how, I talked about yourself, and we were actually talking a lot about self-kindness, self-compassion, putting up boundaries, saying no, things like this, and having people in our life that honor that. So that was she just kind of stopped. She was just kind of smiling and shaking her head. I could see it was resonating for her. And she's like, you just said something that clicked for me. So sometimes it's that type of thing, but also it can be bigger emotions that go all the way back. Right. So I usually will start with PRT, a lot of the, avoidance and exposure. We work with that. And some people, a lot of education go a really long way. I've heard that they estimate, people can read John Sarno's books and like 30% get a book here, right? So just education can be huge. Just like you said, just saying to a patient, you don't have to fear this. It doesn't mean you're damaged. Even though you have hearing loss, it's okay. It doesn't mean your tinnitus can't turn down. And that can be enough for some people. But when they're still stuck and we've done all the education and we've given them avoidance and engagement and they're doing the somatic tracking and they're leaning into symptoms and they know they're safe and they get it, then there's probably emotional work that needs to be done. Yeah. And that can be around boundary settings and relationships, or it can be, deeper work from past hurts and adverse childhood experiences and that.
And I do practice both that emotional awareness and expression therapy as well as PRT, pain and symptom reprocessing therapy. You do emotional awareness and expression
I'm trained in both.
Well?
Yeah, I'm trained in both. I've done both. And I think it's, the EAT is a little bit, I start with the PRT first. And then if we need to, we can go to that. Or I might enlist a mental health provider for help with that. It just depends. I think I'm very good at presenting it and getting them to understand that that's where they are. And I can even do some sessions with them, and it's very helpful. Some people may need to go further, and I always know where my role ends. But having that training and being able to have those conversations is very important. Yeah.
And there's so much people can do on their own to kind of do their own emotional awareness and expression therapy through journaling, through guided meditation, specifically like the Unlearn Your Pain workbook provides. So I think that's amazing that you integrate all that into a traditional practice.
Yeah. And I love IFS, internal family systems, or parts work that, even we don't even have to, I'm not officially trained in that, but I've done some, introductory, I've listened to a lot of different trainings in that area. And so I have quite a bit of familiarity. So it may be just a conversation of like, oh, that sounds like an inner critic voice. How do you feel about that inner critic? I hate it. Why is that inner critic there? Right. And so just making that suggestion of like, the inner critic wants me to do this. Was that a bad thing? No, it's actually a good thing. So now what do we think about the inner critic? Oh, I guess it's trying to help me. So I had another patient I'm working with. She actually was in a car accident and concussion. And, well over 4 weeks later, because concussion typically heals in 2 to 4 weeks. I'm seeing her maybe 6, 8 months out. She's got dizziness. She has tinnitus. She has sound sensitivity. And I'm explaining neuroplastic symptoms, and our brain is trying to keep us safe and creates these symptoms. And she says to me, I think my brain hates me. And I said, so you were just telling about how you don't want to go to Thanksgiving dinner with your spouse's family because they're very critical of your marriage with your spouse. And what if your brain gave you your dizzy symptoms so big you couldn't leave, you couldn't go, you had to stay home?
To protect
and she
you.
thought about it and she said, I think my brain loves me, maybe too much. So she went from this part hates me to it loves me.
Yeah,
almost
betrayal is such a common way people look at their brains, and it's just too bad.
Right. And so I think just suggesting, like, I didn't have to unburden her parts or, investigate, I don't do that, but just being able to say, let's look at that part and the motivation. Because as Dick Schwartz, who, the founder of IFS, all parts are in service to us, no bad parts. So even that kind of mindset shift can be so powerful for people. I find that parts work is like the antidote to the inner critic, right? And self-compassion. But how do they bring in self-compassion? How do they bring in appreciation to a part of them that just beats the crap out of them all the time? It's hard.
Yeah.
So,
well, what else should we know about tinnitus, getting better from tinnitus in a neuroplastic way? Anything else you want to share?
Biggest thing is, when people, how do I know if I have a neuroplastic symptom? And especially if I can't find a provider in this field. And this is part of why I'm out here trying to spread this message is here's a provider in the field of tinnitus telling you confidently, having done tinnitus for almost 18 years, it is a neuroplastic symptom. No matter what the cause is, it can change, it can turn down, it can turn off. So hopefully someone's seeing this and getting that message and having more faith in that diagnosis. The other thing is if you're saying, well, I'm still getting these other diagnoses, my providers are telling me I have these other conditions. The biggest thing to me, I think, one, if your provider is going, right? I mean, or you're getting these vague diagnoses that don't tell you what the structural nature is. Like there's one in dizziness called 3PD, which stands for like persistent perceptual postural dizziness. That's not a diagnosis, just like fibromyalgia or long COVID. It's just a constellation of symptoms. And the other thing is I say, when your symptoms don't make sense, not just to the physician or the provider, but to you, when, okay, I watched TV and it was horrible. And then I watched TV and it wasn't. Like, listen to your own intuition. You have lived in a human body. If you've had that experience before and you weren't concerned and now you do, or sometimes that thing causes symptoms and sometimes it don't. So and I have people say to me, my symptom did this, my tinnitus did that. I don't understand. It doesn't make sense. And I'm like, exactly. That's how we know it's neuroplastic. Yeah. So that would be some things that I would say start to question and listen to your own intuition. Like, because even just when people fill our paperwork out, they'll come in going, I get it. Like just the questions you asked and filling out that stress inventory, I get it. It gives them permission to like listen to their own natural intuition that says, that doesn't make sense. You don't want to say that to a physician who's gone to medical school or, has a doctorate degree in whatever they're doing. But and a good medical provider is going to be open to those conversations. So saying like, I feel like maybe my stress is related to this, or I saw this video that says that tinnitus could be mind body, that it could be related to stress, or I had a really rough childhood. Do you think that could be related? And they may not be able to give you real details, but they'll probably go, yeah, thank you. Yeah, I just didn't know how to say that to you, but yes, I do think that's it.
Yeah. Doctors and other medical providers in the traditional model just they see it. They see it.
They
They're
just
so
don't
close.
know. They know.
They're just not given, and I wasn't given originally the tools to what to do about it. So I would add additionally, if someone out there, maybe they have a diagnosis and maybe things make sense to them with their diagnosis, but the treatment is not helping enough. Maybe there's something that can help in the neuroplastic.
Right. Or it says there's no cure. Like, what are the conditions out there that have no cure that aren't, well, cancer can be cured sometimes, right? That aren't clear structural things like fibromyalgia and yeah, so just find the books,
Yeah.
read them,
I love that
watch the
about
podcasts. Yeah.
trusting your intuition and,
Hmm.
patients, we're really our own best healers, but we have to listen to ourselves.
Yeah.
When I was having chronic arm pain from
Hmm.
repetitive motion use
Hmm.
using a computer at a stressful job, I could play the piano at home. And I
Yes.
didn't really question it. I was like, oh,
Yeah.
who
It's
knows?
different movements.
Yeah,
Yeah. It's
yeah. I mean, it's like one keyboard, another keyboard, and I would play
yeah.
vigorously and,
Hmm.
have no problem until it was really out of control and I couldn't do anything with my
Anything.
arms. But yeah, so I hope this helps a lot of people out there.
Yeah.
I have a feeling there's people who watch this video who didn't really think much about tinnitus for them, but it just adds to the picture of
Hmm.
neuroplastic symptoms, and so
Yeah.
many people have tinnitus as their 10th symptom,
Yeah. Yeah.
their 20th
Right.
symptom. So,
And that's just more
yeah,
evidence too, like, oh, I do have some tinnitus and my hearing was normal. And they said, I don't know.
yeah,
It's just another alarm bell going off
yeah.
in a different form. Hmm.
So, Dr. Marcia Dewey, how can people contact you if they would like to?
So I actually am in Wisconsin, in Milwaukee, and I only practice in Wisconsin. So I am licensed in Wisconsin. So you'd have to make your way to Wisconsin to see me. But we do have a nice website. So you can go to my hospital is Froedtert.com, and I'll have you just link it because it's
Oh,
I won't try to spell it. So we can link it and froedtert.com/tinnitus. And on that website, there's also a link to our sound sensitivity page. So there's some pretty good information there. There's a link to our paperwork. So if you want to look at the paperwork and see some of the questions and see if that resonates for you, or
and
look
maybe
at
there's
the
some
stress
practitioners
inventory.
out there who might be
Hmm.
curious what you put on your paperwork.
That
Yeah.
too. And then I recently started a YouTube page. You can link that. It's my Dr. Marcia Dewey, DrMarciaDewey, all one word, at Yahoo, or I'm sorry, at on YouTube. And I'm just starting it, so I don't have a ton on there, but hopefully over time I'll be adding more. So there's a couple videos and some trainings on there as well for providers, and I'll be doing some that are more geared for patients as well.
Nice. I'm so
Hmm.
thankful to you, Marcia Dewey,
Thank
Dr.
you.
Marcia Dewey. Thank you for your time, and I'll definitely put all that information spelled out under the video. And again, to subscribers, if you could like and subscribe this video to get more like it. Thank you again.
Yes, thank you. This is great.